Good evening, everybody. Welcome to the Moynihan Prize presentation and other prize presentations of the Association of Surgeons of Great Britain and Ireland in the centenary year of ASGBI. Sorry we're not doing this face-to-face, but we're very much looking forward to the Moynihan Prize papers. The Moynihan Prize is the most prestigious prize of the association. It's been in existence for over 70 years, and many of the winners have gone on to very prominent surgical careers, as indeed have many of the competitors. It's a fantastic achievement for the three of you to even get to the final. And of course, we also welcome our other three presenters in the prize three papers this evening, the Neela Prize and the two short papers of distinction that we'll come to later on. I'd like to give a particular welcome to the audience this evening. And before we meet the speakers, I'd like to give a particular welcome to our attending past presidents, of whom there are at least three: Tom Bates, who was president in 2004, Lord Ribeiro, who was president in 2000, and George Parkes, who was the president in 1992 at the Jersey meeting, which was one of the first meetings that I went to and indeed gave a paper, long since forgotten. So we've had almost 70 years of this prize, and we look forward to the three Moynihan Prize papers. To introduce those, I'm going to hand over to our short paper chairs for this evening, Neil Welsh, Vice President of the Association, and Professor Vasilios Papalouis, who's our Director of Communications. I'll hand over to you, Neil, to get things going.
Thank you very much, Ian, and thank you for a good introduction, and thank you everybody for coming along. So without further ado, I'd like to introduce the first paper presented by Nigel D'Souza, who's a trainee in Basingstoke, and he's telling us about, can the fecal immunochemical test rule out colorectal cancer in symptomatic patients? So this is the NICE FIT study. Nigel, do you want to tell us about that?
Thank you for that kind introduction. Ladies and gentlemen, I'm Nigel D'Souza and I'm a trainee in colorectal surgery. On behalf of my co-authors, I am presenting the main results of the NICE FIT study, Can FIT Rule Out Colorectal Cancer in Symptomatic Patients? And I've already moved on to the first slide, thank you. I have no disclosures. So we began this study in response to the national surge in colorectal 2-week wait referrals. Just under 400,000 patients with bowel symptoms were referred on the 2-week wait pathway in England in 2018. Hundreds of thousands of colonoscopies are performed each year to investigate 2-week wait symptoms, but less than 5% of patients will have an underlying bowel cancer diagnosed. This system incurs huge costs and will result in complications in some patients, but importantly, it adversely affects our national bowel cancer survival outcomes, because as you can see on this graph, patients who are diagnosed with a bowel cancer screening pathway are diagnosed at an earlier bowel cancer stage with significantly better survival than patients diagnosed via the 2-week wait pathway. But expansion of the bowel cancer screening program is currently prohibited by the colonoscopy consumption by the 2-week wait pathway. Now, the fecal immunochemical test, or FIT, has been suggested as a possible means to better identify patients with colorectal cancer. This test, which can be performed at home, samples feces with a probe or dipstick that you can see and can measure fecal hemoglobin as a surrogate marker for cancer by immunoassay. The sensitivity of FIT for cancer has been suggested to be equivalent to a colonoscopy, and indeed it has replaced the guaiac-based fecal cult blood test in the bowel cancer screening program. However, high-quality data for its diagnostic accuracy in our population in England is currently lacking. And previous studies on FIT have suggested that fecal hemoglobin in fact varies by age, sex, ethnicity, and deprivation. I'll get the next slide, please. We wanted to investigate whether FIT was an accurate test for colorectal cancer in symptomatic patients in the NICE FIT study. The primary endpoint was therefore to establish the optimum sensitivity of FIT for colorectal cancer in patients meeting 2 great criteria with symptoms. But we also analyzed the sensitivity of FIT across different groups in our population of age, sex, ethnicity, and deprivation to make sure this test could be used throughout our population without missing cancers in any particular group. In the NICE FIT study, patients who were already referred on a 2-week wait pathway with bowel symptoms and who were due to undergo colonoscopy were invited to take part in our study and perform FIT. Their FIT results were then compared to the colonoscopy findings. To create a study of the highest quality and to minimize bias, we employed a double-blinded, prospective, multi-center methodology that was ethics approved and reported to diagnostic accuracy study guidelines. To maintain data integrity, data analysis was performed by an external statistics company independently according to a pre-specified plan in our study protocol. And to ensure our study had adequate power, a sample size calculation estimated we needed 5,400 patients to answer our primary endpoint. So on the basis of work from our pilot study in Croydon, we successfully applied for transformation funding from NHS England and began recruiting patients across multiple sites in London. But when we were a badge on the NIHR portfolio, we were able to recruit collaboratively through the Clinical Research Network, and we started recruiting patients across 50 sites in England. I'll get the next slide, please. In our final analysis, we included 9,822 patients with FIT and colonoscopy results. The median age of study participants was 66, and 55% were women. The ethnic composition of our study population and the median index of deprivation reflected national statistics. 3.3% of patients in our study were diagnosed with colorectal cancer. The most common finding in patients referred urgently on a 2-week wait pathway with suspected bowel cancer was a normal colonoscopy in 31% of patients. Next slide, please. Our key diagnostic accuracy results at different FIT cutoffs of 2, 10, and 150 micrograms of blood per gram of feces are summarized here. Now, most patients with cancer have a high fecal hemoglobin because colorectal cancers bleed. While conversely, most patients with normal colonoscopies or benign bowel disease study, only 19% of patients cutoff recommended by NICE. So if 10 is set at the cutoff for investigation, colonoscopy demand would be reduced by just over 80% while detecting 90.9% of cancers in 2-week wait patients. But FIT can detect fecal hemoglobin down to 2 micrograms of blood per gram of feces on some FIT analyzers. This will test positive and require investigation, but the sensitivity. FIT can also stratify the risk of colorectal cancer, as cancer is found more frequently at higher fecal hemoglobin concentrations. When over 150 micrograms of blood per gram of feces is present in feces, a patient's risk of cancer is 31% in our study. Next slide, please. On subgroup analysis to answer our secondary endpoint, we found no significant difference in FIT sensitivity for colorectal cancer in any toxicity and deprivation at either cutoff. Here are the results for 2 micrograms of blood. And I'll get the final slide, please. So in conclusion, the evidence from this study suggests that FIT could be used to restructure the NICE 2-week wait colorectal pathway, as well as organize endoscopy services both during and after the COVID-19 pandemic. FIT can rule out colorectal cancer when fecal hemoglobin is undetectable or low and reduce unnecessary colonoscopies. FIT can also be used to risk stratify patients when fecal hemoglobin levels are high and prioritize them appropriately for investigation. Analysis of our primary endpoint demonstrate that FIT sensitivity for colorectal cancer is significantly better at a cutoff of 2 than 10 micrograms of blood per gram of feces at 97%. And finally, subgroup analysis for our secondary endpoint demonstrated no significant variation in FIT sensitivity for colorectal cancer. This suggests that FIT could be used for all 2-week wait patients in England, whether young or old, male or female, rich or poor, black, brown, or white. Have the final slide, please. I'd like to thank the committee for the opportunity to present this research in such a prestigious forum, but I'd also like to thank the many people that made the study possible, not just the hundreds of researchers up and down the country, but the thousands of patients that took part in our study. Thank you very much.
Thank you very much indeed, Nigel. Now, I'm going to introduce Pete Sagar in a minute to act as our primary discussant. For those of you who are not used to Zoom, if you move your mouse over the screen, a little chat button comes up at the bottom. If you press on that, you'll see a panel that comes up on the side of your screen, and you can enter questions there that we will put together and maybe have a chance to ask Nigel D'Souza, depending on time. I also noticed that occasionally his video connection stuttered, and we often find that's a problem with bandwidth. And could we please ask everybody who isn't on the panel or discussing their paper to switch off their video feed. So Peter Sagar comes from the centre of the universe up in Yorkshire. He's a well-known colorectal surgeon, and I'd like him to act as the discussant, please, for Nigel's paper. Peter.
Thank you, Neil, and thank you, Nigel, for a very good presentation. Very clear slides too. Now, the question you posed in the title was, can FIT test rule out colorectal cancer? So you had 21,000 patients, 11,000 did the test, 9,000 had colonoscopy. The significant proportion of patients didn't go ahead and have the colonoscopy, about 18% of them. I think this is an important study given the volume of 2-week waits we get. But in answer to your question, your specific question, does it rule out colorectal cancer? Given that fall off, what would you say the answer would be?
Well, we investigated why patients didn't undergo colonoscopy, and they were usually due to clinician decisions at the time. So they were referred to, and they were already vetted to undergo colonoscopy, and a decision at some point between then and the actual test that was done meant that they didn't have a colonoscopy. Now, that might mean they had an incomplete colonoscopy, which we know can happen in 5 to 10% of patients, or it could be that on the day that they didn't turn up, or it could be that they were vetted in the end to another test, such as flexible sigmoidoscopy or CT scan. Now, we discussed whether we should be using a form of record linkage instead as a reference standard in addition to colonoscopy. But we thought that that was a somewhat insecure method that is vulnerable to criticism that you don't know if a patient has a miscancer and is sitting out in the community. And we decided that actually enough data has been generated on that in service evaluations that are happening throughout the country. So we decided to stick to a gold standard of colonoscopy.
When did you start the study, Nigel? In other words, are there going to be a few miscancers? Are there inevitably with colonoscopy? Have you started this a few years ago and you follow them up for a long period, or is this just a 1 or 2 year follow-up so far?
So that's a question I'm dying to answer, but we only had ethics approval and funding to conduct this research over a 2-year period. You're absolutely right. In the longer term, we know that colonoscopies have a miscancer rate, and I am going out of my mind wanting to know what the cause of those patients with very high fecal hemoglobins of over 1,000 are. So I'd like to see their CT scans, see whether they had OGDs, and also follow them up to see if they presented later on with a miscancer. But unfortunately, that data is unavailable. We're hoping to get it from local centres pending ethical approval.
Now, Neil mentioned working up in Yorkshire and Leeds. We've been using during COVID FIT to prioritise patients for colonoscopy or CTC. Please educate me. We've been ignoring people with a score less than 10, putting people in the back burner if it's between 10 and 100, and scoping people over 100. Is that a sensible policy, or are we running a risk there of missing cases or delaying diagnosis?
I think that's appropriate, and I think it depends on your endoscopy services and resources available to you at the time. So I think in an ideal world, free of COVID, what would happen is that patients who are FIT positive at a cutoff of 2 or detectable fecal hemoglobin undergo a 2-week wait colonoscopy, and patients who are very FIT positive, whether that's at 150 or 100, where they have more than a 20% risk of cancer, undergo an expedited next list straight to test colonoscopy if they're fit. But obviously we're in trouble, we're in difficult times, and pragmatically, I think some people decided to use a cutoff of 10 rather than 2 or detectable fecal hemoglobin, although hopefully our study will change that decision. And some people are deciding we should prioritize the patients with very high fecal hemoglobins I am uncomfortable with that because I think, there are a certain percentage of patients with fecal hemoglobin above 10 and below 150 who will have cancer who are sitting there waiting for investigation.
Thank you. Thank you, Neil.
Thank you, Peter. A couple of questions have been asked. Was the uptake of the test maintained in the less affluent patient groups or the more deprived patient groups who often seem to attend screening less? Do you have any feel for that?
So thank you for that brilliant question. And the answer is it was not taken up so well, both in patients who were from lower socioeconomic postcodes, but also from patients who are in ethnic minorities. Now, when we started this study in London, I was inspired by the data in Nottingham that suggests that a postal system had return rates of about 80 to 90% in Nottingham. In London, it was 25 to 30%, completely different. Part of that is because Nottingham were rolling out FIT as a part of a service evaluation, so they had to do it, whereas we were an ethics approved research study, so they didn't need to do it. But part of that is, I think, the differences in the population. We changed our recruitment methods and managed to improve a recruitment to 50% through a few different tweaks to our recruitment methodology. But as a result of this, what we've done is launched a qualitative study looking at how we can increase the uptake of FIT in groups that are older, in groups that are from ethnic minorities, and in groups that are from lower socioeconomic classes, because these are the patients who present with advanced stage disease as a result of the delayed presentation. And they're the group who could really benefit from an early diagnosis test like FIT.
Thank you. One last brief question. How do you explain FIT positive but colonoscopy negative patients, particularly high FIT levels and colonoscopy negative?
I can't pretend I have an answer for that. I think there may be small bowel pathologies that lead to this test being positive. We know from research in Barcelona that patients who are on PPIs have higher fecal hemoglobin levels, and that suggests that although we say that this test is specifically for colonic fecal hemoglobin or colonic hemoglobin, that possibly upper GI hemoglobin that transports down through the GI tract can result in a FIT positive test.
Okay, thank you, Nigel. I'm going to call an end there. Thank you very much indeed. Can I thank you very much for coming and presenting, and Peter Sagar for acting as the discussant. And can I then hand over to Vasilios to introduce the next paper?
Thank you very much, Neil, and very good evening to all from me as well, and welcome to the SGBI 2020 prize session. The next paper is going to be presented by Pierre Montauban. Pierre is a core surgical trainee at Kent Surrey in Sussex, and his work is a randomized clinical trial related to the effectiveness of preperitoneal local anesthetic infiltration versus local wound infiltration following laparoscopic cholecystectomy. Pierre, you have the floor.
Pierre, you have to unmute your microphone.
Apologies. There we go. Hi, good evening. My name is Pierre Montauban. As mentioned, I'm a core surgical trainee, and I'd like to thank everyone for the opportunity to present the findings of our study, which was a randomized controlled trial comparing two routes of administration of local anesthetic during laparoscopic cholecystectomy. Next, please. Next. Thank you. Yeah, so just as a brief introduction, laparoscopic cholecystectomies are one of the most commonly performed operations in the United Kingdom, and we do try to perform them as day case operations where possible. However, postoperative pain is one of the main limiting factors to achieving this. The infiltration of local anesthetic may improve postoperative pain. However, this benefit and the most effective route of administration of the local anesthetic are still in question. Next, please. So the aim of our study was to compare pre-peritoneal local anesthetic infiltration to local wound local anesthetic infiltration in terms of their impact on postoperative pain following a laparoscopic cholecystectomy. Next, please. So for this, we conducted a randomized clinical trial, which we had registered and approved by our local research department. We included all adult patients undergoing a laparoscopic cholecystectomy, We excluded those in which the cholecystectomy was performed as part of another procedure, those requiring conversion to an open procedure, and operations in which the use of local anesthetic was restricted for clinical reasons. We then randomized our patients into one of two groups. In group one, they would receive local anesthetic to the preperitoneal layer prior to port insertion. And in group two, they would receive the local anesthetic infiltration locally to the surgical wounds created for the ports at the end of the operation. The patients were blinded in terms of what group they had been allocated to. Next, please. So in both groups, we infiltrated 0.5% bupivacaine to the skin prior to inserting the first port for the laparoscope. In group one, we then infiltrated the rest of the maximum dose allowed for that patient to the preperitoneal layer under direct vision of the laparoscope, which would allow us to see a bleb being formed and make sure that the ports are being placed through that bleb. In group two, the local anesthetic was infiltrated just under the skin, locally to the surgical wounds created for the ports. And this was performed at the end of the procedure. Next, please. So the primary outcome that we assessed was an assessment of pain using a visual analog scale, both immediately after surgery and 48 hours after. Next, please. Our secondary outcomes included the percentage of patients that we successfully managed to discharge within 24 hours after surgery, and their requirements for NSAIDs and opiates at 48 hours post-operatively. Next, please. We also assessed multiple independent covariables which had the potential of acting as confounding factors and therefore creating bias. These included age, gender, ASA grade, the mean operative time, the operative difficulty score, which we assessed using Sugru scoring system, and the rate of drain insertion. Next, please. So looking at our results, we managed to recruit 148 patients after 2 had met our exclusion criteria. 72 patients were randomized to group 1, and 76 patients were randomized to group 2. So looking at the patient characteristics and the intraoperative details that we obtained, and there was no statistically significant difference for any of the independent covariables which had the potential of acting as confounding factors. Our mean operative time was just over an hour in both groups, and the operative difficulty score was approximately 5 out of 10 in both groups. And this included an assessment of the BMI, which was included within the scoring system. Next, please. So these are our main results. The pain scores immediately after surgery and 48 hours after surgery was significantly lower in the group of patients that had received an infiltration of local anesthetic to the preperitoneal layer when compared to those that had received the infiltration locally to the surgical wounds. And similarly, their requirements for NSAIDs was significantly lower when the infiltration had occurred to the preperitoneal layer. There was no significant difference in the percentage of patients that we successfully discharged within 24 hours. And the requirement of opiates 48 hours after surgery was minimal in both groups. Next. We did encounter a few limitations. So when reviewing the literature, it was suggested that the timing of local anesthetic infiltration may have been important. Just to remind you that it was infiltrated at the beginning of the procedure when infiltrated to the preperitoneal layer. And in the group receiving the infiltration locally to the surgical wounds, this was performed during closure. And there was exposure to some potential bias due to the fact that neither the surgeon nor the outcome assessors were blinded to the randomization of the patients. So our conclusion is that the result supports local anesthetic infiltration into the preperitoneal layer prior to trocar insertion for improved postoperative pain. However, we recognize that larger randomized clinical trials, bearing in mind the limitations that we encountered, would be required to standardize practice. Thank you very much.
Thank you very much, Pierre, for a very clear presentation and for keeping the time. And I will ask now kindly Mr. Christian Makukiewicz, who is our Director of the Scientific Program of the Association of Surgeons of Great Britain and Ireland, to discuss the paper with Pierre.
Thank you very much, Vasilios, and welcome to everybody. Well done, Pierre. I enjoyed your presentation and your paper. As somebody who does a lot of cholecystectomies, it's something of great interest to me. So it's a nice single-blinded randomized clinical trial with 148 patients. Can you tell me how you came to 148 as being the number you needed? Did you do a power calculation, or was this something that was just decided as the unit?
So essentially, we included all of the patients that were undergoing a laparoscopic cholecystectomy over a period well above a year. And of those, we only had to exclude 2. And given that it's a large district general hospital, we felt it was fairly representative and would have a good external validity.
Okay, very good.
We didn't, to my awareness, perform a formal powering calculation.
Given the fact that you've already alluded to the fact that you've slightly changed the timing of when you add the local anesthetic, bupivacaine takes about 15 minutes to start working. It maybe isn't surprising that immediately after surgery, the visual analog score is slightly higher in patients that have had it infiltrated into the wound. You've obviously done or been involved in plenty of laparoscopic cholecystectomies. Can you tell me the usual port sites that hurt the most when a patient wakes up?
So definitely the first port, so the one where we insert the laparoscope, and then the epigastric port.
Sure. So in the preperitoneal patients, the epigastric port would have had a preperitoneal local anesthetic. How did you ensure preperitoneal anesthetic for the umbilical port?
So we didn't. So as I did mention during the methodology, the local anesthetic in both groups was initially infiltrated just under the skin, because we couldn't guarantee where we were actually infiltrating that local anesthetic, and it was better to achieve a higher concentration in a single plane.
Sure.
We would have required to use something slightly more sophisticated, probably an ultrasound, to ensure that we were injected into the preperitoneal layer. That's what we were trying to achieve.
Okay, so that leads me on to my final question. You'll be pleased to know. If you're going to redo this again or get some bigger numbers, do you know of any other techniques for local anesthetic infiltration in laparoscopic surgery? And which ones would you choose, or how would you do it differently?
Well, probably the more sort of user-friendly would be using a bedside ultrasound probe if you want to achieve infiltration into the preperitoneal layer for all your ports prior to the operation. The other possibility is infiltrating directly intraperitoneally into the gallbladder bed. That has proved to have some effect. However, it's being compared to infiltration of local anesthetic to the abdominal wall without any significant difference. And that's mainly been explained by the fact that they have different sort of pain pathways. So we're dealing with 2 entirely different sort of pathophysiologies. But yeah, I think it's all about, so in my view, it's also about the practicity. Using an ultrasound prior to an operation when you're trying to achieve a day case is probably not entirely feasible. But you do have the option of intraperitoneal infiltration at the end of the procedure, which is quick and easy as well.
Thank you. Vasilios, all yours.
Thank you, Christian. Pierre, we have quite a few questions coming from the audience. We will take as much as we can because there are time limitations. The first question is about the group 2. Why you infiltrated the anesthetic in the subcutaneous layer and not just beneath the fascia?
Not just beneath the fascia.
Mm-hmm.
So So for the group that received the infiltration locally to the surgical wounds, this was done at the end of the procedure, so we were no longer within the abdomen at the time. It would have been possible potentially to perform it at that stage. However, at this point, we had already removed the ports, and therefore you can't guarantee at what level within the abdominal wall you are to infiltrate the local anesthetic. And it's just the most accessible and just ensuring that you have an adequate concentration in that tissue plane.
Thank you. And the second question, which is a double one actually, is first of all, how do you explain the need for more pain control when you do the preperitoneal infiltration? Although it was not statistically significant, still they needed more pain control compared to the subcutaneous group.
So no, quite the contrary. So the group that had received the anesthetic to the preperitoneal layer had reduced requirements for NSAIDs at 48 hours after surgery. And similarly, well, both groups had minimal requirement for opiates. So in fact, in the group that had received the local anesthetic to the preperitoneal layer, there was less requirement for analgesics.
And what is your explanation for that?
To be honest, I think that requires slightly more in-depth sort of investigations directed at the pathophysiology itself.
And finally, did you infiltrate the whole lot from the preperitoneal space all the way to the subcutaneous layer in the first group?
All the way, no. So the first 2 milliliters were infiltrated directly to the skin at the beginning of the operation, and then the remainder of the maximum dose we were allowed for that patient based on their weight was infiltrated to the preperitoneal layer to achieve maximum concentration.
Pierre, thank you so very much, and many thanks to Christian for the discussion. And I will pass now the floor to Neil.
Thank you very much.
Thanks very much, Vasilios. And so we have an opportunity to move on to Peter O'Leary's study. Peter is an Irish trainee surgeon, and he performed this study whilst at the Beaumont Hospital in Ireland. And he's evaluating the efficacy of conservative management of acute uncomplicated appendicitis, in other words, the COMMA study. Peter, would you like to take over?
Absolutely. Thank you very much for the introduction, and good evening, Chairman and colleagues. I'd also like to say thank you to ASGBI for this opportunity to present the results of our recently completed COMMA trial. Next slide, please. Use of antibiotics only to treat acute uncomplicated appendicitis is an attractive treatment option for both patients and healthcare providers for a variety of reasons, including avoidance of potential surgical morbidity, a quicker recovery, and less demand on limited resources such as operating theatres. However, there is a lack of consistency with reported appendicitis recurrence rates within the literature to date. For example, the NOTUS study reported a recurrence rate of 13% at 2 years, the APAC trial reported a recurrence rate of 27% at 1 year, and 3 recent meta-analyses on the topic have reported recurrence rates varying between 7% and 39.1% within 1 year. Quality of life is another key aspect that is yet to be comprehensively examined. The only study that has evaluated quality of life to date has demonstrated no difference between surgery and antibiotics at a median follow-up of 7 years. However, this study was limited due to its retrospective nature, the large potential for recall bias amongst the respondents at 7 years, and the fact that all patients that had an open appendicectomy within the study, which in itself can influence quality of life. So in the setting of conflicting recurrence rates and a lack of quality of life data, the COMMA trial aimed to examine the overall efficacy of antibiotic-only treatment of acute uncomplicated appendicitis versus surgical intervention, and also to prospectively evaluate quality of life, cost, and accumulated sick days. Next slide, please. The COMA trial itself was a single centre trial which commenced in September 2016 and completed 1-year follow-up in December 2019. Male and female patients aged 16 and over with right iliac fossa pain, a raised white cell count and/or a raised C-reactive protein were screened for study inclusion. Exclusion criteria included right iliac fossa pain within the previous 1 year, a history of inflammatory bowel disease, and penicillin anaphylaxis. Following screening, patients underwent radiological evaluation with an ultrasound, with or without an MRI if they were under the age of 45, and a CT scan only if they were over the age of 45. If acute uncomplicated appendicitis was identified, the patient was subsequently randomized to surgical intervention in the form of a laparoscopic appendicectomy, or they received antibiotics only, whereby patients were administered intravenous coamoxiclav or Augmentin 3 times a day, and then they were switched to oral coamoxiclav for 5 days once they were showing signs of clinical improvement. The primary endpoint for the trial was defined as the success rate of antibiotic-only treatment for acute uncomplicated appendicitis at 1-year follow-up compared to a success rate in the surgical group, which was expected to be 100%. Secondary endpoints included a comparison of quality of life, cost, and sick days between the 2 study groups. The sample size calculation was performed on the basis of a satisfactory margin of 15% or less recurrence within the antibiotic-only group. And with a study power of 90%, this required a sample size of 93 participants per group, or a total sample of 186 participants. Next slide, please. And now to the results. So in total, we screened 719 patients for eligibility. 533 of these were excluded, leaving us with 186 patients who subsequently underwent randomization. In the antibiotic-only group, 23 out of 91, or 25.3%, of patients developed a recurrence of appendicitis within 1 year. In the figure to the right, you'll see a timeline to recurrence within the first year of follow-up. And you'll also see that approximately 1/4 of the recurrences occurred within 1 month of the intervention. And looking beyond 1 year, we noted a further 6 patients in the antibiotic group that actually developed a recurrence, give you a total of 29 recurrences, or a recurrence rate of 31.9% at a median follow-up of 28.8 months. Next slide, please. As part of the trial, we also sought to assess quality of life at 1 week, 1 month, 3 months, and 1 year post-intervention. At 1 year, the EQ5D index score and the EQ visual analog scale were significantly better in the patients who underwent surgery compared to those who were treated with antibiotics only. In addition, the proportion of patients who reported to be in full health was significantly higher in the surgery group also. As you can see in the figure to the right, aside from 1 week post-intervention where the EQ5D index scores were similar, the remaining time points were consistently higher in the surgery group, which is represented by the green line, compared to the antibiotic-only group, where no recurrence was seen in the blue line, and the antibiotic-only group with the recurrence as represented with the red line. We also evaluated other secondary endpoints, including accumulated sick days, which were 3.6 days shorter for antibiotics only compared to surgery. And we also looked at the mean total cost in the surgery group, which was significantly higher than in the antibiotics. In surgery, the cost equated to, on average, 4,816 per patient, euros, sorry. And in the antibiotics group, this equated to 3,000 euros per patient. However, the mean cost of treatment in the patients that underwent surgery for recurrence was 5,600 euros, which was significantly higher than any other group within the study. Next slide, please. So in conclusion, the COMA trial has demonstrated that antibiotic-only treatment of acute uncomplicated appendicitis is indeed associated with a higher recurrence rate at 1 year and beyond. And these rates were consistent with the previously reported APAC trial. Importantly, for the first time, the COMET trial has demonstrated an inferior quality of life associated with antibiotics-only treatment up to 1 year post-treatment. And perhaps in time, when these patients are followed up, this may extend beyond 1 year. Thus, based on the high recurrence rate, as well as the inferior quality of life associated with antibiotic-only treatment, we believe that surgery should remain the mainstay of treatment for acute, uncomplicated appendicitis. Thank you for your time, and I'd like to take any questions.
Thank you very much indeed, Pete. Can I hand over to Miss Jill Tierney, who's the discussant for this paper. Miss Tierney is Director of ASGBI, and she's also one of the leads in a COVID-19 COVID harem study for appendicitis, as well as being a consultant colorectal surgeon in Derby. Jill, do you want to take the floor?
Flattering promotion, but I'm not the director of the ASGBI. I'm the director of emergency general surgery for the ASGBI. That was really interesting, and I am genuinely fascinated. I've got lots of questions, and I can see there are lots coming in. So nice presentation, nice simple idea. So firstly, can you tell me, you talk about uncomplicated appendicitis. How do you define uncomplicated appendicitis?
So within this study, uncomplicated appendicitis was a radiological definition. So we're very much reliant upon our radiology colleagues, and we agreed upon anybody that had perforated appendicitis, extraluminal layer on imaging, periappendiceal fluid, evidence of an abscess or a walled off collection, and either an intra or extraluminal appendiculate. All of these patients would be categorized as complicated.
And so all those patients went straight to surgery, did they?
Yes, yes. And it's interesting because there is another trial ongoing at the moment called the CODA trial in North America, and they're including some of those parameters, in particular the appendiculate, and they are including those patients in the uncomplicated appendicitis group.
Absolutely. Okay, so that was interesting. So you're a single center. You did, you saw 719 patients, screened them. You excluded a huge number of patients from your study. Why were they excluded?
The largest number of patients were excluded because they had normal imaging, and normal bloods then after that was the second biggest reason.
So do you think normal imaging excludes acute appendicitis?
Excludes them from the study.
Clinically?
Yeah, but it certainly didn't exclude them from exclude appendicitis.
So did you have patients who didn't come into your study because the imaging was normal, but then went on to have an appendicectomy?
Yes, yes. They were treated clinically, and we were very adamant about when we designed the study that we would only be including radiologically proven appendicitis into the study.
Into the conservative group?
No, into the actual trial itself.
Oh, okay. Okay. You don't mention any complications in your operative group. Did you have none?
In the operative group, there were complications. There was 4 patients who had a collection, 2 of which needed drainage. There was 1 patient with a surgical site infection, and that was the entirety of the morbidity within the surgical group.
So just those 2 that didn't have any laparotomy patients in your appendix group? None. No. Okay. Do you know what the average BMI of your patients in Dublin was at the time?
BMI.
Just ballpark. Are they big fellas out there or not really?
We actually didn't measure BMI as one of the parameters, but we're all very slim here in Dublin.
I hear Guinness is great on a diet. So what about this 25% recurrence rate? Now you say that's unacceptable. Unacceptable to whom?
Well, when we designed the trial, we postulated a figure of 15% upon which the trial was powered, which lay in between the 10 to 30% recurrence rate that was reported in the literature. we deemed that below 15% would be acceptable to us as surgeons, and most importantly to the patient. But anything over 15% was excessive and was leading to inconvenience to the patient, more than compromising their safety, because in fairness, antibiotic treatment of acute uncomplicated appendicitis, even from the data in this trial, has a very good safety profile. And it has been one of our go-to options during the COVID era as well.
Absolutely. So your quality of life, if you leave it in, looks horrific. What was the main thing they're complaining of then?
It's difficult to get a breakdown. With the EQ 5D3L questionnaire, there are 5 main points that you can ask the patient about. The standout ones were anxiety and pain.
Interesting. Yeah, as endpoints. How many CTs? So you told us about the breakup of age. Do you have a feel for how many CTs you did then? Was this mostly a young population or an older population?
It was, in terms of the demographics of the population, it was only 15% of patients were actually over the age of 45. So it was a very young population cohort.
So does that mean that majority of your imaging was therefore ultrasound in this study?
Ultrasound would have been done in about 2/3 of the patients, yeah. CT scan ended up being done, I think, in about 1/3 of the patients, off the top of my head.
Okay. And if you came into hospital with acute appendicitis based on this, what would you have? How would you be managed?
Provided that we're not in the midst of a global pandemic, I would absolutely have surgery. What appears from the results in this study is that surgery will impact upon your quality of life for a brief period of up to maybe 6 to 8 weeks. But with antibiotic-only treatment, you're potentially turning this into a chronic condition, and you could still be suffering the consequences of it by a year, as their quality of life has demonstrated.
Okay, I think there's lots of questions from the floor, so I'll hand you back to Mr. Welsh. Thank you.
Thanks.
Thanks very much, Jill. Thanks, Peter. Yes, there are a number of questions from the floor, some of which you've answered already. Something about the criteria for ultrasound diagnosis and its less sensitivity than CT scan. We'll leave that one for the moment. One of the questions, for those people over the age of 45, did you do a follow-up colonoscopy if they recovered with antibiotics from their appendicitis? And did you do interval appendicectomy?
That wasn't part of the trial protocol, and that was at the individual surgeon's discretion afterwards.
And what's the recurrence rate in people with an appendicular abscess? Or did you not, that was a group that was excluded from your study, is that correct? Yes,
we excluded that cohort of patients within the radiological definition that we used for complicated appendicitis. They would have fallen into that.
All right.
So we didn't look at that.
And then why did you choose 3 days of IV antibiotics followed by 5 days of oral?
Sorry, you may have misheard me. So what we did was, once we had radiological confirmation of acute uncomplicated appendicitis and the patient was randomized to antibiotics, they then went on intravenous co-amoxiclav. Most patients received at least 3 doses of that. And then once they were showing clinical improvement, that was followed by 5 days of oral co-amoxiclav. We use co-amoxiclav because it's broad spectrum. It has anaerobic.
Thank you for the clarification. I understand. So 3 doses, okay, not 3 days. Sorry. Okay, thank you. And then the last question I think that someone's asked is, those that did have to go back following failed treatment of their appendicitis with antibiotics, was the operation technically more challenging, or was it pretty much the same?
Really interesting question. Because these patients had been through acute appendicitis on day 1 and had imaging confirming that they've had appendicitis, they were very familiar with their symptoms. So what was happening was these patients were liaising with the trial coordinator, and they were given instructions to go to the emergency department, and they were presenting at a very early stage, which meant that operatively they had early acute appendicitis, and this was backed up histologically as well.
Thank you very much indeed. Well, thank you very much to our discussants, Nigel, Pierre and Pete. Thank you, to the presenters, Nigel, Pierre and Pete. Thank you very much to our discussants, Pete, Christian and Jill. Can I ask all those on the voting panel to check their email link, please, to start voting? And Vasilios, do you want to introduce the next bit?
Thank you very much, Neil. As our president told you, dear colleagues, at the very beginning of this session, we'd love to see you in our Congress and celebrate together live the first century of our association. Most unfortunately, this cannot happen, but we have all other means to mark this historic occasion. In that context, the SGBI team has prepared a short but very moving, we believe, video that captures important elements of the past, the present, and the future of our historic association. We hope that you will enjoy it.
Well, thank you very much for that. And thank you very much for playing it. Now, we just got a few minutes to wait whilst we switch back to the presentations. And what we're about to go on to is the National Emergency Laparotomy Audit presentation. And that will, as you all know, comes out of the data generated by the National Emergency Laparotomy Audit, which has been going for a number of years and has been producing some fascinating data. In a minute, Bav will change the screen to have the presentation papers up. And what we're going to ask then is Giordano Perrin to present his NELA Prize-winning paper on complex decision-making in emergency surgery, a judgment analysis study. We then shall have the opportunity of asking some questions, and then please use the chat button to ask questions that we can then ask Giordano. So Bav, if we can move on to the opening slide, please, Giordano's presentation. And Giordano, if you'd like to introduce yourself and tell us all about your study, please.
Thank you. My name is Giordano Perry, and I'm a higher surgical trainee here in Yorkshire in the Humber region. Thank you everyone for having me today to talk about our work on complex decision-making in emergency laparotomy surgery. Next slide, please. So let's jump straight into it. What was the aim of our work? Well, first of all, we wanted to review the decision-making process for all patients that were coming through our doors with a surgical problem correctable only via an emergency laparotomy. Now, that's regardless on whether that laparotomy actually happened or not. And secondly, we wanted to compare how that decision-making process is carried out by different professionals in our unit, regardless on whether they were involved in the care of those patients or not. Click, please. And when I say different professionals, I mean surgeons, anesthetists, and intensivists. So let's see how we actually get on to reach our aim. Well, first of all, we had to choose some patients. Click, please. So we decided to select the most recent 25 patients based on our NILA database that underwent an emergency laparotomy and survived at 30 days. The most recent 25 patients that underwent a laparotomy and died at 30 days. And finally, based on our M&M presentations, the most recent 25 patients that were considered for a laparotomy, but unfortunately deemed too unfit to survive it and were therefore palliated. Click, please. We went through all their notes, all the 75, and we filled in an electronic data collection sheet, including all the variables that you would normally be expected to find in a general surgical emergency clerking, including a NILA score, the CT findings, and the presumptive preoperative diagnosis. We purposefully took off this pro forma any data about real life outcomes, so whether these patients underwent laparotomy or not, whether they survived or not. Click, please. We then asked a group of anesthetists, surgeons, and intensivists to look at those forms and give us a simple answer. Would you operate on this patient, yes or no? Click, please. And finally, we crunched all our numbers into our judgment analysis. To cut a long story short, we use statistical tools to interpret the decision-making process and understand what variables play an important role here. So for every decision maker, we build a logistic regression model, in this case, a binomial logistic regression. We then compare the goodness of fit between the different models, and that is an indicator of how consistently the decision maker handles all the variables throughout the 75 scenarios. And finally, we compare the importance of each variable between the models. And I'm happy to go into more details about how we do this later on. Next, please. So let's have a look at the baseline characteristics of our patients. So just glancing at this table, you can see that we are talking about pretty much our average laparotomy patients. Age is as average 73 years old. And just a couple of points here on this table, really. We seem to be palliating a significant number of female patients compared to male, as you can see on the second line, fifth column. CCI in this case stands for Charleston Comorbidity Index. It's a general medical index used for basically prognostic indication and life expectancy based on comorbidities. The frailty score is our average frailty score. And finally, if you look at where these patients were coming from, this is pretty much in line with what we have seen in the NILA database itself. Click, please. Let's have a look at our preoperative diagnosis. Well, as you can see, the king here is lower GI perforation, with the vast majority of these patients being diagnosed with a diverticular perforation. There's a couple of perforated large bowel cancers included here in that group. A couple of notes on this table. We have separated obstruction and adhesion of small bowel obstruction. When we talk about obstruction here, we mean generally a cancer-related type of obstruction. There's only a couple of cases of ghost scenarios here, and adhesion of small bowel obstruction has been considered separately because of the different prognosis it does carry. And finally, if we look at the NILA score for our patients, our average was 17.8%. And as you expect, this escalates from 9.4 to 17.9 and 26.4 throughout the three cohorts. Next slide, please. So let's start having a look at the results of our judgment analysis, where we had 8 consultants involved in our study. for a total of 600 yes or no responses. Of note, 30 patients had a green light from all 8 consultants. Of those 30 in real life, 18 were survived, 11 died after laparotomy, and 1 was palliated straight through the door. 6 received the red light, so they would not be operated on by all 8 consultants, and all of them were palliated as they came into hospital. The chart on the right is a representation of the concordance between the real life decisions and the decision that the decision maker would make based on preoperative variables. And as you can see, the concordance on average is just shy of 80%. But what I really want to highlight, if you look at the column here, is that there is a huge variation between what different consultants would do faced with the exact same information. And that is pretty much true throughout the 3 cohorts of patients. And there doesn't seem to be a particular pattern considering surgeons, anesthetists, or intensivists on their own. Next, please. So this is really the core of our judgment analysis results. The middle column represents the variables that on binomial logistic regression are statistically significantly associated with a decision for a yes or a no. And as you can see again, these variables are very different for different consultants. The column on the right represents the goodness of fit. So again, how consistently the decision maker handles the variables throughout the 75 cases. And as you can see, there's a huge difference between different consultants. Next, please. This is probably the most important chart of the entire talk. As you can see, we have some numbers on the x-axis going from 0 to 0.7. It could potentially go up to 1. The higher the number, the higher the importance of the variable for that particular decision maker. On the y-axis, we have the particular variables that we included in the judgment analysis, clustered obviously for the purpose of the analysis. The legend represents the single consultant. So if we look, for example, to surgeon 1, we can see that age was fairly significant as a variable in his decision-making process. Comorbidity index, not so much. NILA, a little bit more. Frailty scale was actually very important for that particular decision maker, and so on for all the consultants involved. What I want to reiterate here is that these dots are scattered throughout the chart to, again, testify how really all these decision makers are valuing these variables in a very different way. Next slide, please. So to conclude, we could say that different clinicians do take different decisions when faced with the same information. Next, please. So we could say that it's true that many of the truths we cling to depend greatly on our point of view. And if we do have different points of view, perhaps getting all these points of view together might be a good idea when handling the care of emergency general surgical patients and might do them a very good favor. Thank you.
Giordano, thank you very much. That's absolutely fascinating. Can I just ask a few questions of my own? What do you think accounts for the difference between the consultants? It doesn't seem to be their native speciality. Why do you think people vary?
Well, it's a very difficult question to answer. I can answer subjectively. I think there's a strong cultural component to it. And I see that in my normal practice. And there is obviously a previous experience related component that can swing us towards, taking a decision versus palliation or versus performing an operation. We did not look at where all these consultants were trained and how significant their experience was. That is because the cohort of actual decision makers was relatively small, so I don't think we would have had relevant data out of it.
Okay, and then did any element of patient choice come into this? Because occasionally you get people who come in and say, I know you want to operate on me, doctor, but you're not going to.
Of course. So obviously the main limitation of this study is that we cannot fully replicate real life decisions. So we purposefully excluded, based on the notes, patients where there was a clear decision or a refusal of treatment from the patient perspective. There needed to be a specific decision taken by the consultant looking after the patient that that patient was not suitable for a laparotomy.
Okay, and can you think of any ways of perhaps making better decisions or decisions that are in the best interest of the patients? There's been a lot of talk about different ways of decision making involving numbers of people, including the consultant surgeon, intensivist, and sometimes others as well.
Yeah, we seem to be heading towards that model in our, well, in the institution where this study has been conducted, particularly following this experience that we had looking at our own patients. Obviously, it's taking some time for this to be picked up, and I think it will take some time for us to see some results in terms of reduction, perhaps, of our mortality rate after laparotomies. We should probably look into implementing something like this in a bigger scale, perhaps, and see how that influences our NILA data.
Okay, thank you very much, Giordano. I'm going to pass you back to Vasilios, who I guess has been looking at some of the questions been coming in, and see if you can answer some of those. Vasilios?
Thank you, Neil. Congratulations, Giordano, for your excellent work. There are quite a few questions. I will try to bundle the first two. What do you think are the weaknesses of the design of your study? And what more particularly, you have included 9 consultants in your analysis. Is this number big enough to allow you to get to some sound conclusions?
So I think the main limitation is related to the inability to replicate real life circumstances, particularly, relatives involvement and potential, the bedside impression that we all look at when we are judging an emergency laparotomy patient. And I think that's really the core, but I don't think that that is correctable in any way, really. I believe the second question was related to the number of consultants. Yes, there is definitely a limitation there. What we are doing at the moment is actually refining our database of patients and including some positive and negative controls, and using this at a larger scale, hopefully regional level, to get a bit more meaningful data. The core methodology of this comes from data back in the 1990s, suggesting that the main limitation here is really the number of scenarios rather than the number of decision makers involved. And the number of scenarios needs to be calculated based on the number of Qs, aka the variables that we include in our analysis. And that's at least 5 to 7 scenarios per variable. And we are just about meeting that criteria based on 6 scenarios per Q. So, yes.
Thank you, Giordano. Another question is about the age of those consultants. What was their range? And was there any correlation between their age and the decision-making process?
Great question. I admit I don't know the age of all the consultants involved. I can say that based on the 3 consultant surgeons that are involved in the study, because I know them personally, there doesn't seem to be a particular pattern. The most junior of the 3 is pretty similar in terms of the concordance with real life, with the most experience of the 3. And the one in the middle sits in a very different category in terms of age and experience.
And
so, no.
One last question for me, if I may. You have a very robust model here and very robust analysis. Did you give a chance to those consultants to come together in the focus groups afterwards and discuss the outcomes of the study? Because I think that it would be enormously important to have their input in this qualitative setting.
Definitely, no, that's a very good question. So we didn't have a chance to get them all together, but we did have, at the point where we were communicating this data to them, informal meetings with them. And we probably should make this more formal, but there was a lot of surprise, particularly from some consultants, with the discrepancy between their decisions and the decisions that some of their colleagues would take. Particularly one anesthetist thought that he was particularly generous in offering a laparotomy to some patients, where he was actually the most conservative one of the 3. So that would definitely be something we will take on board and try and do in a more formal way.
Thank you very much, Giordano.
Thank you again,
Thank you.
Giordano. Thank you for coming along to present, and I hope everyone enjoyed that. I just wanted to let the panel know who are voting on the Moynihan Prize that the voting is closing. So could you please put in your vote? And Vasilios, do you want to move on to the short papers of distinction?
Thank you very much, Neil. And this is the last part of the evening before the announcement of the Moynihan Prize. We have two papers that have earned a distinction by the Association of Surgeons of Great Britain and Ireland. And the first one is going to be presented by Dale Thompson, and it's about ambulatory management of right iliac fossa pain, a 5-year review. Dale, you have the floor.
Good evening. My name is Dr. Dale Thompson. I'm one of the CT level clinical fellows in general surgery and simulation at the Royal United Hospital in Bath. And I would like to thank the panel for the opportunity to present our experience of the ambulatory management of patients with suspected appendicitis. Next slide, please. Excuse me. Emergency surgical ambulatory care opened its doors in Bath in 2013. It has subsequently provided care for over 9,000 patients, with 92% of patients being managed on a fully ambulant basis. We run a consultant-led service every weekday from 8 AM till 8 PM, and patients are assessed in a morning clinic where there is access to dedicated ESAC diagnostics. This is followed by a daily afternoon operating list, which runs independently from the 24-hour Seaport emergency theatre. ESAC has proven to deliver a well-regarded service to patients, with 98% of the patients willing to recommend the service to friends and family. Right iliac fossa pain is one of the most common presentations to the acute surgical take. In the UK, there are around 50,000 cases of appendicitis per year, and the incidence is increasing. However, in our centre, around 31% of the patients referred with suspected appendicitis will go on to have surgery. Managing appropriate patients on an ambulant basis can help to reduce bed pressures, ensuring beds in emergency theatre space are reserved for the sickest patients. A recent meta-analysis published in the British Journal of Surgery by Van Dijk et al. Showed that there was no increase in the complication rates, with delays to surgery of up to 24 hours following the admission with uncomplicated appendicitis. This provides further evidence that the management of select patients with acute appendicitis on an ambulant basis is appropriate and safe. This topic is especially relevant in the context of the current COVID pandemic, where a priority to reduce unnecessary bed stays and try and get the patients home to shield has been a priority. Next slide, please. We identified all referrals to ESAC of patients with right iliac fossa pain or suspected appendicitis from a prospectively collated database between January 2015 and December 2019. All patients were over the age of 16 years old, in line with ESAC policy. Cases were excluded if they'd had a previous appendicectomy. Furthermore, inpatients who were operated on the ESAC list to assist with pressures in emergency theatre were excluded. 661 patients were identified, and females outnumbered males 515 to 146. 375 of the patients were initially triaged and deemed appropriate for ambulatory management by the on-call surgical team. The other 282 patients were direct referrals from GPs, the emergency department, or other inpatient specialities. Next slide, please. So 84 patients were diagnosed with acute appendicitis in ESAC. 81% were taken to theatre for appendicectomy. The remaining patients were managed conservatively. None of the conservatively managed patients represented to hospital within 30 days with recurrence of symptoms or underwent appendicectomy. 27 of the operated patients were operated on the dedicated ESAC list and managed on an ambulant basis. On average, patients admitted to the take for operation in the emergency theatre had double the waiting time for operation over patients who were operated on the daily ESAC list. There were no reported complications from patients who underwent appendicectomy on the ESAC list, and there were no readmissions within 30 days or return to theatre. Next slide, please. A diagnosis of non-specific abdominal pain is generally defined as acute abdominal pain of less than 7 days in duration, where there's no diagnosis reached after examination and baseline investigation. This cohort of patients were discharged from ESAC with no follow-up or outpatient investigation. One patient from this cohort of 369 returned within 30 days for a laparoscopy under the care of the gynecologists. However, at laparoscopy, they were diagnosed with acute appendicitis. 84 patients underwent further investigation for abdominal pain, with 24 of these patients admitted to the acute take and 60 patients managed on an ambulant basis. None of these patients underwent appendicectomy within 30 days of initial assessment in ambulatory care. Estimated bed days saved were calculated using an algorithm we formulated from a local pilot study of inpatient surgical patients, identifying the average wait times where no intervention occurred, which was described as red hours, and associated with specific interventions, whether this was the diagnostics or a clinician review, and that was green hours. From this, we're able to estimate an average length of stay. As such, we estimate an average saving of 189 occupied bed days per year and financial savings of around £48,000 per year on occupied bed day stays. There were no adverse outcomes identified by managing patients on an ambulatory basis with suspected appendicitis. Next slide, please. In conclusion, the ambulatory management of patients presenting with right alar classic pain is safe. With increased experience and confidence in this pathway, we are able to become more aggressive in ambulatory management of suspected appendicitis. Hence, repeating the study in the near future would be useful to review the impact of increasing experience. It presents an excellent opportunity for financial savings and reduction in unnecessary excess bed days occupied. Management of patients on an ambulant basis can lead to improved patient experience due to the access to dedicated ESAC theatre lists and diagnostic slots, leading to a reduction in red hours where no intervention is taking place. However, emergency surgical ambulatory care requires robust infrastructure and staffing to offer an effective service. And I'd like to thank you for listening to my presentation.
Thank you very much. Very clear presentation, and congratulations for your distinction. A couple of questions for me. First of all, you gave us a very clear description of this ambulatory service, including even the financial advantages of it. What are the limitations to it?
The limitations to, can I just ask from what point of view, sorry?
From the point of view of clinical safety, from the point of view of implementation of the service per se, in day-to-day practice in any hospital across the UK.
Okay. So obviously the limitations are the patients are being initially triaged and making a decision that they would go home. So the initial bloods would have been done from, if they'd been triaged by the on-call surgical team, and assessed briefly. Obviously, the limitation would be from a safety point of view that the patient could go home and become more ill. However, we extensively safety net all of our patients to ensure that's not the case. In terms of one of the limitations with the current ESAC theatre list is that the theatre list is so busy that we unfortunately are at the minute having to admit quite a lot of patients to operate on them on the take list. So an actual improving service would be to increase the amount of theatre space via an ESAC list to ensure that we can provide the excellent service across the board.
So if it is to give one piece of advice to a hospital that wishes to adopt a similar approach, what would that be?
It would be to have a dedicated pathway with excellent to have a dedicated pathway with dedicated slots for diagnostics to ensure that we can manage the ambulant patients so they can come into the ESAC clinic and ensure that we can get all the diagnostics that we need to do done so we can safely make a plan for them. If there's no dedicated diagnostics, I think it's difficult to run the clinic efficiently.
And one last question for me. Did you have to make modifications in this approach, in this clinical pathway, in the context of the pandemic of COVID-19?
So in the context of COVID-19, the ESAC pathway has been reduced. So initially when we reduced when the when lockdown began and the pandemic started. Initially, the ESAC was cancelled. However, as the pandemic has evolved, we've restarted with a reduced number of clinic spots and dedicated diagnostics. So that's how we've managed it at Bath. However, as the pandemic is evolving, we're able to get back up to more normal levels of seeing patients, but we're essentially just reducing the numbers across the board.
Dale, thank you so very much, and I will pass the floor to Neil for questions from the audience.
Oh, thank you very much, Dale. Very few questions from the audience, apart from how difficult was it to set up ESAC. And I think most of us have been through that in our own hospitals, and it is not easy. It requires dedicated time, facilities, personnel, and space. So I'm going to call it to a close this time. Thank you very much indeed. And I'd like to thank Vasilios and Dale for that short paper, and move on to Aaron on the quality of sleep during non-resident nights on call. Aaron, are you able to, you're connecting with video now.
Yes, hi there, hi everyone. And thanks for the opportunity to talk today. I am having some internet issues, so the video may go off through the afternoon. I'm very grateful to ASGBI for selecting this paper. I'm also aware of the irony of me as the consultant presenting this from home, while the two registrars who are the first authors are both on call. But I'm looking forward to talk a little bit about the quality of sleep during non-resident nights on call. Next slide, please. Now, in multiple professions, in multiple areas, not least in medicine, there have been numerous studies that have looked about the impact of a lack of sleep or poor sleep, and in particular, the chronicity of poor sleep or lack of sleep. And in airline industries, in technology, in engineering, and of course in medicine, poor sleep is associated with numerous factors such as impaired performance, poor decision-making or rushed decision-making, or decision-making that protects the individual rather than thinking about the service as a whole. It's also associated with adverse physical effects and behavior patterns, which can be unlikely or unusual for the person making or exhibiting those behaviors. In medicine, those naturally lead to potential risks to patient safety. And these risks have been documented in a number of different medical specialties, particularly anesthesia and emergency surgery. However, nights form a large proportion of on-call rotas. It is inevitable that virtually all subspecialties have to have some degree of night work, and increasingly patients and hospitals expect and demand a consultant-delivered care of service 24 hours a day, 7 days a week. Not just a consultant-led service, but a consultant-delivered service. And the challenge really is how we as consultants are able to square the circle, try and deliver with fewer people a consultant-delivered care throughout the day and night. Next slide, please. So the aim of this study really was to start as a pilot study really, to try and analyse and compare the quality of sleep between nights when a consultant surgeon is on call versus nights when the consultant surgeon is not on call as a control group. And the Fitbit Versa sleep analysis software was used. And this is a fairly freely available part of the Fitbit Versa watch. And analysis were carried out on the sleep patterns during consecutive periods of the on-call rota and compared to matched nights during the elective period of the rota when the consultant surgeon wasn't on call. And 14 nights of on-call were compared to 14 nights of control. And the sleep analysis produced by the Versa software was compared. Next slide, please. An example of the kind of thing that's produced every night at the end of sleep. And you can see it broadly splits up stages of sleep into 4 areas: time spent awake, time spent in light sleep, time spent in deep sleep, and time spent in REM sleep. Light sleep is broadly your entry point into sleep from being awake. During this period of time, you're easily awoken, but light sleep itself has a positive impact on life. It promotes mental and physical recovery. Deep sleep is needed for feeling refreshed in the morning. And it's harder to waken from deep sleep, and it's associated with physical recovery and the immune system, as well as having some positive impact on memory and learning. REM sleep is again a crucial part of sleep and associated with mood regulation, learning and memory. And what the software does every night, it gives you your kind of sleep analysis, tells you the proportion of time that it thinks you spent in each stage of sleep, and it compares to your own 30-day average, but also to a benchmark of all of the analyses of sleep that the company gets from presumably lack of privacy from their software, and compares your sleep analysis to the benchmark for someone of your age and BMI and so on. And next slide, please. Next slide, please. Now, over the results for a single consultant surgeon, what was interesting was that there were some significant differences between quality of sleep and amount of sleep during on-call periods of time compared to time not on-call. On an on-call period, the subject went to sleep over an hour later compared to when on elective time, but also woke up earlier, over half an hour earlier on a night than when not on call. The total sleep was lower per night when on call, over an hour and a half, and each night of the sleep over the study period, both on call and not on call, was actually lower than comparable benchmarking figures. You can see that the time spent awake was almost 3 times the benchmark figure when on call, and there were significantly lower periods of time spent in REM or deep sleep. When on call, or even when not on call, it took almost half an hour to fall back into even light sleep after any interruption, be it a phone call or even waking up to make a decision. And over a quarter of nights were associated with the subject not returning to, sorry, 3/4 not.
Aaron, I'm afraid we've lost your voice as well as your image. You may have to repeat that bit when you get signal again. We'll give you a couple of minutes to see if you come back.
Am I back on now?
You are.
That's great. Next slide, please. So in summary, really, nights during on-call were associated with less sleep and worse sleep. And every interruption rarely led to falling back into deep sleep. All aspects of sleep were worse when on call. And when you extrapolate these results from previous sleep analyses, it does suggest a potential impact on cognitive and decision-making abilities. Now, we know that over the last few years, junior doctor rotas have reflected the need for periods of rest and maximum working hours. And these results, to my mind, support the suggestion that consultants in high acuity specialties should consider shift working to maintain good outcomes for their patients and probably themselves. Thank you very much, and I'm happy to take any questions.
So Aaron, the immediate question I have is how many times was the consultant on average interrupted or called at night when they were on call?
Well, I suppose that's going to vary between consultant to consultant and on-call rota, but during this study, the consultant was interrupted usually on average every 45 minutes to every 65 minutes, so about once an hour.
Okay, so that it's not just that they were lying awake thinking about what might be happening in the hospital, they were actually being interrupted on an hourly basis.
Yeah, and also interestingly, they went to sleep later as well. And I must say, from a personal point of view, when you're on call, you probably do stay up a little bit later, just in case that call comes through.
Yes, that's certainly, I think some people do that. I actually personally do exactly the opposite, on the expectation I need to get as many hours as I can, but there we go. So do you think that shift working would be better? I mean, because we now have a whole lot of evidence that shift working itself is not terribly conducive to a lifestyle and or decision making either.
Yeah, I think there's going to be a balance between the two. And I think all too often shift working gets a bad press because the shifts are terrible. But if the shifts are associated in a unit or in a department where you get good periods of rest between shifts and good periods of rest for a prolonged period of time after shift, then to my mind, that is probably a healthy balance between long periods of working and shift working. At the end of the day, we've also got to think about the impact on the patients. And I know, sorry.
I'm going to pass you over to Vasilios now because I see a number of questions have come in that he's going to ask you.
Thank you very much, Neil. Thank you very much, Aaron. Very interesting. One important question is that there are some other factors, like, for example, the consumption of alcohol that can reduce sleep quality. Were participants told to abstain on nights that they were not on call? And if so, how did you manage to recruit?
Yeah, as a rule, I'm pretty sure the subject didn't drink when on call. I suppose it was a non-blinded study, and I'm reasonably sure that there was no alcohol during the on-call periods of time. But you're quite right. Some of those other factors weren't compared for when not on call. So yes, I'm afraid I'm able to comment on the alcohol consumption on non-on-call periods. But yes, you are right. That does have an effect on sleep.
And one last question. Evidently, the work that you have done gives us an objective way to see the effect of the on-call in the sleeping patterns. Have you thought of expanding this kind of work in different ages of surgeons and different specialties?
Yeah, well, I think that, I mean, this is a very early preliminary set of data. And to my mind, one of the things I really don't know is how good this software is and whether there are better objective analyses of sleep compared to something you can buy freely on the market. That said, it's something that can be bought freely on the market, so could easily be expanded to a whole consultant group and so on. So I think that would be very valuable to look at different specialties, different ages, different gender and so on. And yeah, I mean, certainly that was our aim. In fact, I was hoping to roll this out across the whole department, but then coronavirus has struck over the last few months. But yeah, I certainly think that's going to be something that will be interesting and valuable in our department in coming months to have a look at.
I can tell you with my other hat on as a transplant surgeon, we will be desperate to be part of your studies in the future. So, Aaron, thank you so very much for a very important piece of work. We are most grateful to you and the colleagues who asked the questions. And that brings us to the very last element of today's special session, which is the presentation by our president, Professor Ian Anderson, of the winner of the HGBI Moynihan Prize of 2020. And Professor Anderson will also close the session. Ian, you have the floor.
Thank you very much, Vasilios. Thank you, Neil, as co-chair. Thank you for chairing so well, and thank you to the management team for organising this evening and for preparing that excellent video that we all enjoyed. I hope all the presenters, Nigel, Pierre and Pete, have their videos on again. Thank you to them, and thank you also to Giordano, Aaron and Dale. I don't think I've heard 6 so clinically relevant talks to our everyday practice in any prize session at ASGBI before. And we've covered really a remarkable range of things, from sleep deprivation, appendicitis, how we make decisions in NELA, and how we inject local anaesthetic in lap chole. With regard to the Moynihan Prize, I'm very pleased to announce that the 2020 Moynihan Prize winner is Nigel D'Souza, with Can the Fecal Immunochemical Test Rule Out Colorectal Cancer in Symptomatic Patients? So 3 excellent presentations. Many congratulations to all 3, and particular congratulations to Nigel and his Moynihan winning presentation. So a big round of applause from all of us, and we look forward to seeing you in Glasgow 2021, if not before. But thank you all for 6 excellent presentations. Thank you very much all. and good night.
Good night.